Hello everybody and welcome to the HealthTech Pigeon podcast, where we take a deep dive into the week's best health tech stories so you don't have to. Today I am delighted to be joined by my colleague Daisy from SomX and our special guest today, Dr. Rosie Scott from Definition Health. Rosie, how are you doing?
Yeah, I'm really good, thank you. Had a good week sitting in the sun. Really good.
It's been glorious, hasn't it?
Thank you for having me here.
No, we're very, very happy to have you. Daisy, how about you? How's your week been?
Oh, I'm a changed woman now. The weather's nice. I absolutely, my mood has completely changed. I picked up. I am just a much happier person all around. And yeah, it's been a good few weeks.
Certainly is a mental health booster, isn't it? I mean, I've got to say, I've been a spring in my step over the last week as I've been going to various places and doing fun things in the health space. But so we've got a lot of really exciting stories to talk about today, some very interesting perspectives to bring out, and looking forward to talking to Daisy and Rosie about both of those over the next hour. But I guess just to start with, Rosie, I'm really keen to hear a bit about what you're doing at Definition Health. You know, what are you working on? What's the big problems you're solving, and what's exciting in your days at the moment?
Yeah, I'm really happy to share all my experience with you. It's quite a treat, actually, just to be able to reflect and give you my perspective on what's happening in my world. So obviously, I have a few hats on, and Definition Health is one of them, and I'm co-founder and medical director of Definition Health, which is a digital health platform to support surgical patients. But I'm also a radiologist, so I've had a clinical week this week as well, working in front of my PACS monitors, doing my MRIs and my injections and things. So I'm often wearing different hats, so I have different perspective depending on which hat I'm wearing, and quite often I'm wearing all the hats at the same time. So from Definition Health, we're just building and scaling, really. You know, we've been around for a little bit now, since 2018, and we started off with our base product, I would say, and we've just basically been implementing that and learning as we go with feedback from the staff, the patients. So now we're in a position to really, you know, sort of, I was going to catapult. I'm not sure that's quite the right word, but, you know, go forward with everything we've learned in terms of, you know, governance, regulations, you know, UX, accessibility, all those sort of things that we've ploughed back into the product. And so as co-founder and medical director, I'm in sort of, over the years, my role has changed slightly from doing everything, putting out the LinkedIn posts, and I never wrote any code or anything like that, but, you know, everything but, I would say. But now we've got a really strong team, so a lot of it's just managing them, really, and creating an overview and a strategy.
Fantastic. And just in terms of, you know, the problem that Definition is solving, you know, what's the kind of focus, what's the kind of key, I guess, the key benefit?
Yeah, well, as I say, I work in the hospital, and we can see lots of pain points in the hospital, and have done over the years, but quite often you're firefighting, so it's difficult to sort these things out. But there came a time when we realised that, you know, I had a bit of knowledge to address some of the pain problems. The ones my co-founder is a surgeon, and one of the main problems they have is getting patients into theatre in a way that is great for the patient, great for the clinicians, and great for the hospital. And, you know, the legacy way of doing it was largely paper-based, understandably, but the world's moved on a little bit. And during COVID, there's much more appetite for digital solutions. Although we existed before COVID kind of helped, you know, to give people the impetus to take digital technology forward. So essentially, we do a pre-op assessment, which patient does at home. So it means they don't have to come into hospital unless they really need to. We're really keen to take the opportunity to sort of add colour to a pre-assessment. So if you're not going to do it face-to-face, let's add photos and videos and patient information and everything you possibly can to make the whole, just by not just digitising it, you're making it better. That's how I'd like to see it anyway. And then we do have a post-op module. So you're taking the patient right from pre-op to post-op on their journey. And that's the most exciting thing, really, because you then get real insight into, you know, what pre-operative factors might influence post-operative outcomes. And there's a whole data piece around that, which is, super exciting.
Sounds like an exciting time. I mean, there's obviously a lot going on in kind of the digital side of surgery. There's a lot of transformation quite quickly over the last few years. Are you seeing that, the pace accelerate there, or are we, kind of getting to that post-COVID point where things are starting to even out and balance out with we've got a really good platform across the board now, and we can kind of stick with what we've got?
Oh no, there's always room for improvement. I still think we're early stages, to be fair, and different hospitals are at different stages depending on their budget, depending on their management, their leadership, their strategy. There are lots of solutions out there, and with my other hat on, so my other hat's a digital integration leader in the hospital. It's not in surgery, but in radiology and pharmacy. How do you choose, or how do you look at all the different solutions that might be available and apply them to your particular hospital? So it's a bit of a sort of a matchmaking scenario, really. What does the hospital need? What can the solutions give, and where can that be knitted together, really? And I think that takes a bit of time, a bit of conversation, a lot of experience. And I think the important thing is for the innovators to keep the conversation going with the clinical staff, because we're in there's a potential of being in our little vacuums. We're there innovating, and the hospital are doing their work, and they don't always understand the benefits that digital technology could bring to their day-to-day work, because it's not part of their day-to-day work unless somebody comes in and shows them. So it's conversation. It's a work in progress. It's exciting work in progress, and I think we're part of it. I like to think we're part of it, but we're not there yet.
It's something we've been talking a lot about recently in HealthTech Pigeon, but also at SomX with clients as well. Is that piece of how do you engage with the people who would be using your solution day to day? How would you actually have those conversations? As you say, a lot of people working in clinical life, there's no reason for them to see the tech, but it's how do you get them engaged, and how can, particularly from an industry side, but how do you make the space for those conversations with clinicians? How how do clinicians make the space for kind of that problem identification piece, and kind of working with the right players in industry to kind of make change happen?
Yeah, I mean, that's great, such a great question, and so relevant, really. I don't think there is a one size fits all, to be honest. There are lots of different ways that innovation companies can connect with clinicians, but it's largely now, it seems, through the health innovation networks, the HINs. That's one way of doing it. They provide the connection between the industry, perhaps, and the hospitals. There's lots of different health innovation networks throughout the UK, and they're starting now to work more together. So if one solution is working well in Sheffield, then it might work well in Brighton, for example. So they have to do their networking communication at the HIN level. And there's other ways too. I'm part of the clinical entrepreneur program, and I'm a big advocate of that. I think it's great. There's lots of clinical staff who are, as we are, sorting out the problems that we see on the ground, if you like, and trying to bring them into real life. So that helps a little bit, helps you with the language. Other ways, the ICBs are slightly dependent on the ICB and on what their priorities are and how they're organised. How else? There's the NHS Accelerator Programme. That's another way, just creating connections. A lot of it is connection, to be honest. Presenting, talking, going to meetings, networking, all the normal kind of things. But there isn't a single route, I would say.
Yeah, lots of diversity, and something I think we're going to probably talk about today in some of the stories. So without further ado, let's start talking about this week's stories. So our first story comes to us today from Digital Health, and it's an opinion piece that HealthTech is the UK's hidden gem and the government can't ignore it. Rush Shaw, founder of Tech London Advocates and Global Tech Advocates, has written a piece arguing that the UK could be a dominant player in health tech in the years to come, rivaling its status that the UK fintech sector built over the last decade. He points to the already impressive number of businesses and people employed in life sciences to show its promise, but says that with the right investment, an effective regulation strategy, and smarter approaches to procurement from the NHS and wider UK healthcare, this number could be even larger, and the UK could be a global leader and dominant in health tech. He does end with a warning, though, that without this investment, we could end up staying where we are, a net importer of health tech, and potentially find ourselves slipping the other way, and points to some notable examples from the life sciences space where this is already starting to happen. So it's a, I think, very optimistic article, and I think really good to see the promise of what could happen. Rosie, you've had a look at this. I'm very interested in your perspective, as a founder, as an innovator, and as someone working in this space. What were your takeaways from this?
Yes, well, it's a big topic. I think that here in the UK we are in a valuable sort of position and poised really to take on the world. So I say, throughout the world we have the same healthcare issues, really, don't we? We have staff capacity, we have increased patient demand, increased diagnostic capability, and probably not quite enough money to deliver it all in the traditional way that we have done. The NHS is the single payer sort of institution, I think, I don't know if it's in the world, but definitely in the Western world. And so I think people look to us, what works well in the NHS. And so lots of the innovations have been, tried and tested with the support of the NHS, and that goes with support from Innovate UK and SBRI grants and things like that, who are supporting us to, support the NHS. So, I know that, I've been on the ABHI program, which takes innovations out to the US, because the US, having the same problems, are looking to the UK to solve some of their problems, because they think, well, if it works well with the NHS, then, it's a good chance it might work in the US, although they have a slightly different hat on. They're slightly more, well, how can we make money, in the NHS? Well, how can we make patient care better and quality of care and deal with staff capacities issues? So they come with a slightly different angle. But, with all the clinicians, the motivation, the life science networks that we've got here, I just think, this is the best place to be. And we just need to start to be confident about that. And it'd be lovely if we can capitalise on it outside of the UK.
Fantastic. I mean, yeah, I think obviously it's an opportunity that's sort of waiting to be grabbed. I'm interested now because even before this article, one of the things that stands out is the kind of regulatory approach. And it's a criticism levied at the UK, but also, Europe's approach to kind of regulating health tech and regulating innovation in this space as well. I wonder, you've presumably had to navigate some of these challenges through probably your work on different sides of things. Are we doing enough there? Should we be looking? I know there's some interesting approaches to kind of simplify regulation, streamline regulation for UK health tech. Are we heading in the right direction?
Well, I think regulations are essential. They keep the innovators safe and the government safe and the patient safe. So I think there has definitely to be regulation. It is always a challenge for early startups to keep an eye on all that and to tick all the boxes when you're starting out, because it all requires financial outlay, cost. Somebody has to help you with the regulation. It's time, it's resource. So while you're there with your great idea, thinking this is going to change, the way I manage my patient in outpatients, you still have to, keep a really close eye on regulations. And is it creating a problem for us? Is it too difficult? I don't know. It's a challenge, but I think it's got to be done. And maybe we need more central support for that, central guidance. Probably resource money to help us, to adhere to all the regulations. But I understand why they're there. I think they're good. They're solid. But you have to be careful not to exclude the really bright innovations that, haven't quite got that bit sorted yet. Maybe marry them up with somebody who has, create a network, an ecosystem, somebody who does the regulation, somebody who does the bright ideas, and somebody who does the implementation. So maybe it's more working together as a team. But I think with the support from the regulatory bodies to guide you through that, to make it a positive thing as opposed to a blocker.
It's that approach of how do you kind of coach someone along a space rather than shutting the door at the early stage, isn't it?
Yeah, I mean, we're all going to benefit, aren't we? You don't want to. There is that worry that it could act as a door that's slammed in your face. Oh, it's too much. It's too much. But actually, it should probably be seen as an opportunity. And as I said right at the beginning, I think it helps to keep all parties on the same page, patients safe, and actually all of us safe, if you have regulations. So I look at it positively.
Definitely. Daisy, how about you? What's your thought?
Yeah, so I have some thoughts on this as well. It's something that I've been talking to one of my friends recently. And I really like this article. I think it's very positive. And I think it has a lot of good points to make. But I think one thing that is probably missing a little bit, but maybe it comes into the unlocking the investment, is that for the UK to keep up, I think we also need to be looking at how do we keep the innovators, people with the good ideas, these people working, making these things happen. Because the US is very competitive for wages. So how do we keep our homegrown talent that, is brilliant? And I think that's something as well that we could probably be doing a little bit more of, is just, when there is competition, if we want to be the top, we need to make sure that we're offering a reason for people to stay. It's something that the UK could do, especially if there's more investment and there's more capital in health tech, and especially if we want to, with everything recently with the export tariffs, I do think it's that we really need to look into is how the finances and how we are getting people to stay in the UK for their health tech, biotech, med tech innovations.
Yeah, I guess it's. I mean, completely. It's valuing it, isn't it? It's what value do you put on it? Is it a monetary value? I mean, the article talks about bringing money into the country. But it's not just money, is it? Just by doing innovation and making a process more efficient, it has numerous other knock-on effects. Staff capacity. It's not just the business itself that you sell. It's the staff capacity. It's the carbon footprint you're going to reduce. All these other little. If you get the systems right and you get the innovators sorting the problems out, everything else just falls into place. But the problem is, I know that, all the people I know who've started innovating, particularly the ones on the clinical entrepreneur program, we've all started doing it in our spare time. No, we don't get paid for it, or, unless you turn it into a business and then you take a salary or whatever. But right at the beginning, you're in your living room at the weekend, think, oh, this is a good idea. And so there probably needs to be some time that's allocated, if we're talking about the NHS and NHS staff in particular, for that. And I think we should be using our own homegrown solutions because we know it fits the way we work. You don't really want to bring something in from another country that maybe was it suited their way of working, but doesn't really suit our patient flows, our staff, the way our unique NHS works. But so we do have to support our innovators, but it's not cheap. It costs quite a lot of money to develop a product. Developers are expensive, and the regulations are changing. So sometimes you have to change your product in order to meet those regulations. So where does that money come from? So who's going to give the money? That's a big question, isn't it? Where does it come from?
It's a really interesting question as well. The piece about, because the piece that then goes into the question about a smarter procurement strategy, and it's interesting, Rosie. We should be using homegrown solutions, and it's a call we've heard quite a lot recently, and particularly there was an AI based imaging company that recently went bankrupt, but on the way out, its CEO criticized an NHS a centralized NHS England procurement program and funding program that where all of the contracts went to competitors in Australia and India, and it did raise that challenge of, for an organization trying to obviously promote better healthcare outcomes, but also, there is a responsibility from the centre to kind of promote those homegrown solutions. Should we be pushing more in that? Should there be more of a focus on, the kind of local or, national focus on the kind of homegrown talent that looks at homegrown solutions above solutions from outside of the UK?
I mean, yeah, absolutely. But how do you do that if you're on a procurement committee and you're faced with 2 or 3 solutions? Maybe the one from Australia is a little bit cheaper, or maybe they present it in a different way, or anything really. But on your procurement checklist, it probably won't say, "Are you from the UK?" I don't know how that would pan out really. How do you add extra points, if you like, for being a UK grown and all the benefits that would bring, not just to that current contract that you're going after, but all the other contracts after that? It's not just, I think the way procurement often happens is contract by contract, hospital by hospital. But obviously, if you've got a contract at one hospital, all the other hospitals will benefit too after that. People sometimes don't look at the bigger picture. What's a wealth of experience that we're going to keep in the UK, that the innovators are going to get, the hospitals are going to learn from, and how can we then spread that out further within the NHS? So, you can tell that I'm very, very pro homegrown talent just because I see it all the time. Honestly, all these ideas that I see on the Clinical Entrepreneur Programme, from, drones going down the Thames delivering drugs to somebody designing a feedback form for staff at the end of the day to say, well, this light bulb's gone or whatever, and you don't leave it for the next person to do the next day. You just need little things that we know work in our NHS, and we have the wealth of talent.
That sounds like nods for Appian and Medish out there from the
they're great
examples. Great companies, great, solving really, really interesting problems. So, very exciting stuff. It's really refreshing to hear a perspective like this, and I think it is an important part of how we kind of boost the sector. I'm very interested to see if there is a response from the relevant people in the right places to this letter, and it's a campaign definitely for us to watch closely. But with that, I will take us on to our next story. So our next story today comes to us from Aunt Minnie, and that is that Covera Health has launched an AI platform for women's imaging. The team at Covera Health have launched a new AI-powered platform called Protect Her, designed to spot early warning signs of breast cancer, heart disease, and osteoporosis, all through routine imaging like mammograms, chest CTs, and X-rays. Protect Her utilizes AI to analyze routine imaging studies to identify early signs of potentially underdiagnosed conditions, many of which disproportionately affect women over the age of 40 as well. So I think, really positive impact and really positive initiative coming out of Covera Health. Rosie, I think this is very much in your wheelhouse, so really keen to get your thoughts.
Oh, I love this. I just think it's great. So radiology is an interesting specialty. It's really hard, I think, to go into a hospital without, I always say, having a blood test and an X-ray, CT, and MRI and ultrasound. Very, very heavily reliant on it, and we're doing more and more and more, which is great. But obviously, there's a wealth of information there. So you may come in with, let me think, maybe I don't know, during COVID, it'd be a suspected clot on your lung. And at that time, as a radiologist, you're trying to diagnose the clot on the lung or not. You may be less concerned about, I think Covera was talking particularly about, arterial calcification in the breast. It's not your focus at that time at 12 o'clock at night. But so I think but you have that wealth of data there. And, with our picture archiving systems, you can go back over years and go, well, actually, that was probably there 8 years ago. So to have an AI platform just to scoop up everything else that perhaps isn't in your immediate specialty or your immediate priority in the middle of the night when somebody's acutely sick and say, well, actually, you haven't got a clot in your lung, but we've noticed that you've got a bit of arterial calcification, or one of your vertebrae looks a little bit, out of kilter or something, and so that's brilliant. It's just an extra pair of eyes, a big filter, a scoop, and just gives us, and this is the question, somebody the opportunity to act at an earlier stage. And I would say that's the challenge. Who's going to act on these incidental findings? I would say incidental or extra findings on a scan or a CT. And that's the tricky thing. Because if I say, well, you haven't got a clot and the AI's picked up some arterial calcification, you sort of have to put that in context. Is that a 20-year-old lady or a 6-year-old lady? Is that clinically relevant? Isn't it? You need to put some extra layers on, some extra context. But also, what happens then? Does the GP get a letter saying, oh, we've noticed some arterial calcification, can you treat the patient? That's extra work for them. Is it useful work? So that needs definitely some thought. Once you've got the information, what do you do with it?
It's a really interesting question. I hadn't thought about it in the kind of, just that kind of early piece of having this around, because, the classic stat of radiologists have to interpret, at extreme levels, multiple, 3 seconds to look at a certain image and make a call on yes or no, or what they've been briefed to report on, and anything incidental may be missed as a result. So there's, huge impact in this, but presumably, as you say, there's incidental findings may require, specialist input that perhaps the radiologist isn't necessarily the right person to give. And if it goes back to the GP may not have the specialist expertise in order, so we'll have to identify and potentially move on. There's quite a lot there. How do we pick up on that? What's the, not expecting you to come up with a answer to the much bigger question today, but what would be the route forward?
We need to have protocols and pathways. I think we need to know, and if you have some osteopenia, which basically is where you lose a bit of substance to your bone at the stage before osteoporosis, there needs to be a clear protocol on how that's treated. There needs to be a way that you inform the patient. You've got some osteopenia, and that creates a whole level of anxiety for a patient. Oh no, what's that? Is that bad? And necessary, unnecessary. Not. You have to gauge that. I think it's protocols. Is probably money. Again, if somebody's got osteopenia, you should probably be on vitamin D or calcium or doing some extra exercise. Where's the program for that? Who's going to implement it? Whose responsibility is it? Whose responsibility? It's not the AI's responsibility. It's not really the radiologist's responsibility, but it's probably somebody's. But whose? So I think the fact that we can pick up all these extra things, I think, is just phenomenal. We, but picking things up on an early stage in the NHS, we're so used to treating things when it's all gone wrong. When they've got the breast cancer, when they've got the cardiovascular disease, or they've got the symptoms from it. We're perhaps not so good at addressing things before they become clinical. And I know that's the way that we should be doing it, and that's public health systems, and that's GP practice and primary care. But that's funding, isn't it? Again,
ultimately, it all comes down to money, doesn't it? Sometimes. Daisy, how about you? What's your take on this?
Yeah, so I think this is definitely the way that we should be using AI. I know AI gets a bad rap in many other areas, like art or journalism, but I think this is really where AI can really do some real good. And I think it's something that we should be fostering. It's something that this kind of stuff hopefully makes takes the pressure off, but it also highlights things that we can't see. I would say, and I think this is no new comment on AI. It's just how is this data being trained? What are the biases? What are protector doing to try and make sure that their data set is as unbiased as possible? And also, I was starting to think about this, and obviously we know that it's not just women who can get breast cancer, and it's men as well. So it'd be really interesting to see the data behind it and to see like how many instances of male breast cancer go into this, or how well it does at detecting breast cancer in men versus in women, and what ethnicities have gone into this data. So I think this stuff's really great, and if the data behind it is solid, then like absolutely we should be doing this stuff. And it sounds like a really interesting tool.
Yeah, absolutely. It's how you train the AI models, isn't it? You have to train them appropriately in order to get the results out that are representative of the population. Absolutely.
This takes us very nicely into our final story of the day, actually, which is a study in Nature, Trust in AI-Assisted Health Systems and AI's Trust in Humans. In a paper published last week, a team led by Madeline Sagona highlights the bidirectional nature of trust in the use of AI in healthcare. AI systems rely on humans for high-quality data and input, just as patients and providers rely on these tools to make accurate, fair decisions. Mutual dependence sets AI apart from traditional medical tools, says the paper. Argues that focusing narrowly on explainability or user confidence misses a deeper point. Patients' broader trust in the healthcare system shapes how they perceive AI, and your relationship with AI may depend on how much you trust healthcare generally, and obviously for some groups that does vary. It comes with a series of recommendations in how to build and sustain trust in AI-assisted care, which, as any healthcare approach should, involves rigorous empirical research, equitable algorithm design, and shared accountability frameworks. So there's a lot in here. Some very interesting perspectives on whether you trust AI and whether you trust healthcare as well, and the relationship in there, but also whether providers and clinicians themselves should trust AI. So Rosie, again, I'm going to come to you on this one, because I think you will have had more interactions with AI than me and Daisy, but very keen to get your views.
Yeah, well, it's fascinating, and it's such an exciting time. But I think the thing about AI in a healthcare setting is the fact our healthcare data is personal, and it makes us feel vulnerable if it's not treated well. I think that may be different to banks and shops and things like that. So I think that's why this is so emotive. And I think it's an evolving space. I remember going to our big radiology meeting probably 10 years ago, and AI was all over it. We've got to do AI. It's going to change the world. Do it now. But we should have done it yesterday. But actually, since then, it's just slowed down a bit. People have realized, yes, it is great, but in the right setting, with the right regulations, understanding the accountability that comes with that, and also figuring out how we truly embed it into our clinical practice. So going back almost to the previous Covera, how do we embed screening, all the scans we do for particular women's health pathology? Yeah, that needs a bit of a conversation for sure. I guess any clinical relationship that you have between a patient, a hospital, healthcare provider is based on trust. And, more than anything else, because our health makes us feel vulnerable. So if you haven't got the trust, you haven't really got anything. And if you're then transferring the trust onto an AI, machine or algorithm, that has to go with it, doesn't it? It's all part of it. And I think, AI, we are a bit scared of AI, aren't we? We think our data is being stored and used for purposes that we don't know about. And a lot of it's around ignorance, maybe, because of what we don't know rather than what we do know. So we need the understanding, don't we? We need, maybe the AI companies to explain how they created their algorithms, why they feel they're safe, how they should be used. And then we need, as clinicians, to work out how best to embed them in our workflow. Without making extra work.
It's straight back to the Covera piece, isn't it? Because it's I think a lot of industry, when they're kind of developing AI tools, thinks of how do we make it as easy as possible to use. And the Covera press release is an interesting one, because it is very much that integrates seamlessly within the radiology workflow. It's looking at the scans while you do, and it's an additive, it's an assistive thing. It comes in and then it's there for you at the end. But it almost it's easy to use, but it's then what do you do once it's done the thing? What happens to that information? And I think probably patients and clinicians are probably equally going to have that level of, okay, what next? What happens in, how does it fit within a kind of much wider picture rather than the kind of one person's workflow, right?
Yeah, completely. And we're all pretty much embedded in how our workflow works, and haven't really got the bandwidth to take on something else. So there has to be a conversation of how's this going to make my life better, and also, slight suspicion: are you trying to make me work harder? You're trying to get me to do more in less time just because we've got a bit of AI supporting us. So it's a tricky one. I just think we've got to keep talking, keep those corridors of conversation open, and admit or try and understand the limitations of it. And I think there are some limitations, but also the immense benefit that comes with it as well. And sometimes those as the AI company, you're probably only going to say the benefits, aren't you? And as the hospital, you go, well, we can't do this, or what if it does this? So somehow we have to be on the same sort of talking platform and maximize and understand the true benefits that it can bring.
The accountability frameworks piece is a very interesting one, isn't it? It's like, because right now we quite often look at, and in fact regulation looks at it as the final kind of burden of using AI. The final responsibility sort of lies with the clinician, and this suggests something. I think that kind of distributes some of that responsibility and accountability across the developer, the organization, and the and the clinician, and I guess looking more widely as well. What's your take on that?
I mean, I don't know if not sure the AI companies can take clinical responsibility. They can create the software, can't they, and put the data in and create the platform. I don't know what the answer is. I can think of an example. That's something we're trying to do in our local hospital, is use AI for reporting CT heads in the middle of the night. So, if you come in and you bump your head, or you fall over, or fall down some steps, or whatever, chances are you'll get a CT head. And the workload is huge. Many of those will be normal. Many will be normal. But you have to do it from a medical legal point of view, a clinical point of view. How many of those could you put through an AI machine and say, well, actually, we're 99% sure those are normal, so we don't need to report those till 8 o'clock in the morning? Yeah. Are we happy to delay reporting them for 4 or 5 hours? So who's going to make that call? Is that the radiologist going, well, I think I'll leave it for 5 hours? Or is it the clinicians in ED who are saying, yeah, I'm happy with the AI. I'll sit on this, not sit on this patient. I'll pause on this patient until the morning, and then make my clinical, and then discharge them. Or can I discharge them based on an AI report? At the moment, I think there's a lot of people are worried about medical legal. We're worried about making mistakes. We're worried about not treating patients properly, and there's very little tolerance of for that. So if AI makes us feel safer and making clinical decisions, that's great. If it makes us feel vulnerable, not so great.
Makes a lot of sense. Challenging issues to discuss in a 1-hour podcast, though, and I think a conversation that I think is going to carry on for quite a long time. And I think, as you say, we need to keep talking. Rosie, thank you so much for joining us today. It's been a really interesting episode, and I only wish it could have been longer. If people want to get in touch with you or find out more about you or the work that you're doing, or Definition Health, what's the best way?
On LinkedIn. LinkedIn's probably best. I have an email address, rosie@lifeboxhealth.com. It's been a pleasure. Thank you so much. A real treat, and nice to share some of my perspective. Thank you for that. Thank you for the time.
Oh, well, thank you. Thanks, everyone, for listening as well. You can find the stories that we've discussed today, as well as some of the best jobs, podcasts, and events in health tech in the newsletter at healthtechpigeon.com. Thanks for listening. We'll see you next week.